Hello, everyone. I am Eliza Riley, your host for the Holistic Menopause Solutions Summit. Today, I am honored to introduce you to Dr. Jerilynn Prior. Dr. Prior is an award-winning endocrinology clinician scientist and professor at the University of British Columbia. With over 45 years of expertise in women's reproductive health, she is renowned for her pioneering work on estrogen-progesterone balance. Dr. Prior's innovative approaches are reshaping how we understand and address hormonal health, particularly in areas like perimenopause, menopause, and osteoporosis prevention. In 2002, she founded the Center for Menstrual Cycle and Ovulation Research to provide accessible, evidence-based resources. Her extensive career includes over 300 influential publications, and her research has empowered countless women with knowledge about their hormonal health. Dr. Prior, thank you for joining us today.
I'm very happy to talk with you.
Happy to have you here. So let's start by having you share a general overview of the hormonal changes that women experience during perimenopause.
All right, thank you for letting me answer that question, because wrongly we're told that it's all about dropping estrogen levels, and that's incorrect. In the process of, or the transition into menopause, when estrogen and progesterone are naturally low, we go through a period where estrogen is not only high, but it's swinging. It's higher than it is in a sexy 20-year-old during the perimenopausal years. And then it drops precipitously. And that drop is related to night sweats and hot flushes, to depression, and to bone loss. So it's a time of chaos. And it must be understood as and treated as different than menopause.
That's really interesting. I appreciate that. So you mentioned the time of hormonal chaos. Could you explain how the fluctuations in estradiol and progesterone levels specifically contribute to the symptoms that women experience at this time?
Yes. So the high estrogen levels are related to things that women may or may not experience, like sore breasts or shorter cycles they do experience, but often don't notice. Things also like very heavy menstrual flow. That's not fibroids. That also makes fibroids grow, but the most of the time, it's because of high estrogen and not enough progesterone that we get that flooding menstruation. The other really difficult situation is those women who get migraines, because migraines can be extremely difficult to deal with in perimenopause. All of those are high estrogen signs. Now, so that's high. How about the dropping? Because it drops and then it goes high again. That's part of the process of getting rid of follicles that could make estrogen or make pregnancy, because we don't want those around when we settle into the blissful, actually, low, steady levels of estrogen and progesterone in menopause.
That's such an interesting point that you make. I think that so often women at this time of our lives, we're trying all these different things, and sometimes we get some good results and sometimes not so good. But we could, if I'm understanding you correctly, we may have migraines and then they go away, and we assume it's because we're doing something, but it could purely be because the estrogen has dropped.
That's true, or is now steadily low, because migraines occur in response to change also. Mm-hmm. But high estrogen is associated with them, so is the birth control pill.
That's really interesting. So one of the things that women, especially perimenopausal women, they wonder if they're actually perimenopausal. You know, how can women know if they are perimenopausal? So what are some early signs or key changes that they should look out for?
Okay. So what's important to know is that doctors are taught that perimenopause only begins when cycles become irregular. Okay. It's peculiar because there's a period of time that we've tracked in many, many women that I experienced myself, where all of the things that are typical of perimenopause have already occurred, except irregular cycles. So the things that are typical and can tell you that you're in perimenopause are a change in your cycle length to shorter than you had it before, or a new onset of night sweats, or new onset of night sweats, worsening of sleep problems. And typically it's waking suddenly in the middle of the night after you've been soundly asleep, and then feeling agitated and not being able to get into a restful sleep again. Other things that are common are increased cramps, the migraines I mentioned before. Some people will have chest pain, or irregular heartbeat. That's quite troubling. I once described it in trying to teach the emergency room doctors what this was like. I said, it's a chameleon. It mimics all kinds of other things. So you have to understand that, or you're not going to be able to perceive it in the difficult situation of a woman who's in distress in your emergency room. The other and difficult thing is that heavy flow happens to about a third of us. And often that heavy flow is associated with cramps that we had when we were teens that got better when we were in our regular menstruating life, and now they come back again, which is also quite peculiar.
Yes, it is. I'm smiling because I'm recognizing myself in everything that you just said. And I think I had those symptoms for a decade before my doctor said menopause.
Sometimes I wish I could tell women to just lie and say my periods are irregular and I'm having these troubles, because then doctors could see that it was perimenopause. Unfortunately, that hasn't happened yet, but there's increasing evidence that there's this long period of time before women get a diagnosis that is horribly distressing when the doctor says, yeah, you're not in perimenopause, you're not in menopause, so sort of go away and don't bother me, kind of thing. Or you must be depressed. Let's start you on this SSRI, this depression or anxiety medicine. Well, maybe you are depressed, but it's the dropping estrogen that's causing it. Or maybe you are anxious, and again, it's the dropping estrogen. It increases stress hormone levels. Plus, it's not fun. As soon as you start getting these things, you think, now I'm old. No, you're still in midlife. You're still in young midlife. So it's a terribly stressful time, especially when your experiences are not supported by those who are paid to care for you.
Absolutely. I so appreciate that you're sharing what you're sharing with us today, because so often women go to their doctors and get, like you said, antidepressants and anxiety that was my story, anxiety medications for many years. And it truly made the anxiety worse. And that was my story. That's my story. But
and most of those medicines make sleep worse, which is not helpful at all.
Yeah, absolutely. So you've highlighted that progesterone can help manage. I apologize. I think I skipped something. Sorry.
Okay.
So many people associate estrogen as the primary hormone involved in perimenopausal changes. Can you explain the role of progesterone during this transition and why it's crucial to consider not just estrogen, but also progesterone?
Okay. I think we have to put that in a context, because within the normal menstrual cycle, we think of it as estrogen being the important hormone. But progesterone, after we release an egg, it comes in very, very high levels and is a very important complement or counterbalancing to estrogen. Estrogen makes things grow. You could put it with any cell, any tissue, anywhere, and it would make it grow. And as long as you kept estrogen there, it would keep growing. Progesterone slows that growth and allows the cell to become differentiated or to do the thing it was meant to do. And therefore, in the normal menstrual cycle, the balance of estrogen and progesterone is important. And the balance is all off kilter in perimenopause. Estrogen's high and progesterone is steadily dropping, even if we continue to ovulate. We don't quite know why, but the amount of progesterone produced becomes lower over time. So there's a clear imbalance of these two hormones in perimenopause.
That's really interesting. So you've mentioned that progesterone can help manage symptoms like night sweats and sleep disturbances. Can you expand on why progesterone is effective for these symptoms and how women might think about incorporating progesterone into their care?
Okay, so first of all, we don't quite know how and why hot flushes work. For example, how estrogen helps menopausal after you've been a year without flow, hot flushes, and it does. There's no dispute about that at all. The dispute is that progesterone can also work. And progesterone works for menopausal hot flushes. And in a trial that was published in 2023, we showed that it also works for perimenopausal night sweats and improves sleep. It also improves sleep in menopausal women, and there's tons of evidence about that. It actually increases deep sleep and decreases the time to fall asleep, increases sleep efficiency. So it's the most physiological thing to help if sleep is a major problem. Now, the issue is that no one had ever tested women for treatment of night sweats and hot flushes only in perimenopause. They always had mostly menopausal women there, or a mix of the two, or only menopause. And because experts think that that perimenopause and menopause are part of the same thing, they say, oh, well, menopausal hormone therapy will work. But it has never been shown to work. And if estrogen's already high, what might be the cost of giving more? So when we set out to do this randomized controlled trial, and it was funded by the Canadian Government Research Institute, we didn't know how many women we would need. We knew you needed about 100 women if you were testing hot flushes in menopause. And so we built in the trial to increase the numbers, and we increased all the way to 189. And even that was not quite sufficient for the primary outcome in that trial. So the results that were positive, were clearly positive, were ones in which we asked the question, how have your hot flushes changed? How have your night sweats changed? And they could say it got better on 5 points, or it got worse on 5 points, or 0, it didn't change at all. And women were blinded when they answered these questions. And what women answered was that night sweats were significantly improved over placebo, that daytime hot flushes intensity were improved, but not the number, and that sleep was remarkably improved.
That's amazing.
Mm-hmm.
So it's interesting because so often we talk about how there aren't enough studies done on women for these types of things. So I love that you're doing the studies and you're getting the results and showing such improvement. Are there another thing that women tend to get a lot of conflicting advice on is specific forms or doses of progesterone? I'm wondering, what do you recommend, or should it be tailored individually?
No, I think it's the only kind or dose type of hormone administration that's been shown to be effective is by mouth. So they're little balls that are oral micronized progesterone. They don't look like other tablets. They are spherical, like a basketball or a soccer ball. And we need 3 of them to mimic the level of progesterone, because we can only take them at nighttime. We don't want to go to sleep when we're at work or driving our car. So when taken once a day, 300 milligrams is needed to keep progesterone in a luteal phase range, a post-ovulatory range, for the whole day. So that's what we've tested and that's what we've shown works.
Very good. Conventional treatments like menopausal hormone therapy and birth control pills haven't always proven effective for perimenopausal symptoms in studies. So why might this be, and what alternatives could be beneficial?
Okay, first of all, there has been one study big enough potentially to show something of birth control pills in perimenopause. But remember, birth control pills are high estrogen. They need to be to prevent a fertile woman from getting pregnant. So high estrogen plus women who already had high estrogen doesn't make a happy situation. And in fact, their flow got worse for the first 3 months on birth control pills. And overall, it did not show that hot flushes were better on the birth control pill than they were on placebo. So that was a negative trial. The problem is that menopausal hormone therapy, which tends to be estrogen with a dab of progesterone thrown in, or progestin, a synthetic, most commonly, unfortunately, has never been tested only in perimenopausal women. So why do the guidelines say that it's effective? That is truly puzzling because it is not scientific, and common sense says if your estrogen's already high, and the reason it's high is because the normal feedback loops are broken so we can get rid of those follicles that make estrogen, how would more estrogen help?
I can't imagine that it would.
No, it shouldn't. And it might very well cause things like blood clots and worsen migraines and worsen weight gain and all of those other things.
Absolutely. So for women who are currently on menopausal hormone therapy or birth control symptoms, or birth control for symptom relief, what steps would you suggest if they're interested in exploring progesterone-based options?
Okay. Unfortunately, the first and hardest job is to convince their healthcare provider that this is an appropriate therapy. So the first thing they need to do is to develop a relationship. And I would suggest that they say to their family doctor, here's this study that was published last year. It shows progesterone is effective and it also shows it's safe. Could you give me 3 months trial? I'll keep a record of for a month ahead of time of how my hot flushes and sleep and everything are. And they can use the free perimenopause diary on the CeMCOR website. I'll keep that record so we know how I started. And then I'll keep that record over 3 months and we'll both learn whether it's helpful or not. So that is the way medicine progresses. It's a trial of one person trying something that's new for them. In the process, they will be helped, I'm very sure, and their physician will have learned something that can help other women.
Absolutely. And hopefully their physician is open-minded enough to try this with them.
And if not, don't blame them because gynecology has not taught family physicians true physiology. They still are not. And for example, at the University of British Columbia, where I teach, I am not allowed to teach about perimenopause. It is left to the gynecologists, and it still has that high estrogen, that estrogen is dropping, blah, 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 and you need menopausal hormone therapy, and it's still not reflecting what the science says, and that's not okay.
It's not okay, and it explains why so many women are so confused.
Mm-hmm.
What you're supposed to do, and you can see a dozen different doctors and get a dozen different avenues to healing.
Mm-hmm. The other thing, it's kind of it's a natural thing that we would go to the drugstore and look at all the things that are in the women's health section and say, well, this says it's good for menopausal health. This is, this has these herbs in it and they sound quite good, chasteberry and ginkgo biloba and all these things. But all of these things made from vegetable sources are estrogenic rather than progestogenic. Progesterone was originally derived from the Mexican wild yam, but our bodies can't transform the Mexican wild yam into progesterone. That has to be done in a lab. So none of these herbal things are going to help unless you really believe they're going to help, and they may help for a while and then they stop helping.
When we've talked, I've noticed that you prefer the term menopausal hormone therapy, or MHT, rather than hormone replacement therapy. Could you
Absolutely. Absolutely.
There's
nothing the matter with me. I'm menopausal. I'm proud of it. I think the great creator gave us a break from the demands of estrogen and progesterone, so that we can focus on our grandkids, so that we can do unique research, so that we have the energy and the independence. Because, if we're not trying now to attract partners, and if that isn't the goal of our lives, then we're free as individuals to do what we are best able to do. So I think menopause is a blessing for women. And the idea that it's a horrifying stage of threatening disability and, and the wrong notion that estrogen and progesterone are going to prevent aging, that's just stupid. We can do a lot to prevent aging by good sleep and good exercise and healthy, fresh food, and happy relationships and purpose in life, but hormones don't do it.
I love that. And I agree with you in all of that. So do you feel that the shift in language, reflects a change in how we approach hormone use during perimenopause and menopause?
I hope so. But I'm so sick and tired of people calling menopause perimenopause, or meaning perimenopause when they say menopause. The word menopause should only be used for the life phase that begins a whole year after the last period. Anything before that is perimenopause.
I agree with you. And I loved hearing that take from you, because it totally shifted how I have viewed menopause.
Good.
Yeah, thank you.
That's great.
Thank you so much for sharing such valuable insights today. I truly enjoy talking with you every time we speak. I learned so much, and hopefully our audience has as well. For those who want to learn more about what you're doing and connect with you, where would you recommend they go?
Okay. The Center for Menstrual Cycle and Ovulation Research, called CeMCOR, has a very large website. We're in the process of refreshing it, upgrading it right now. But it has articles for adolescents, for premenopausal, about infertility, PCOS. It has a lot of information about perimenopause and some less information about menopause. If you want to ask a question, I still try very hard to answer questions from all over the world. I never know where they're from. It's got a Gmail address. Who knows where it's from? The email is info.cemcor@ubc.ca, and there's a contact us or ask us section on the website as well.
Wonderful. And I will make sure that we link that for our audience below. So they can see that.
Thank you.
Do you have any resources that you'd like to offer our audience today?
Yes. First of all, there's the open access, and that means that in order to get it in a journal that was open access, we paid a fee in order to make it so. That the publication was, and I can give you the URL, was in the Scientific Reports in 2023. My name, Prior, is at the first, and if you put in perimenopausal night sweats, it will come up automatically in Google. And then you can read it yourself and you can share it with your doctor. We also want to give away 2 books. They're called Estrogen Storm Season, Stories of Perimenopause. So early on, I had a horrible time, and I'm a pre-baby boomer, and therefore there was almost nothing accurate about perimenopause at the time. So as an endocrinologist, I was observing what I was experiencing myself and trying to make hormonal sense of it. At any rate, I realized after I'd done a huge review that was in Endocrine Reviews, the top endocrine journal, that nothing was changing. The message that family doctors got, the message that gynecologists believed was the same. So I decided to write a novel. My first degree was in English Lit. So I decided to write a novel, and I made up 8 different women with different problems in perimenopause, and they all saw a fictitious doctor. And I kind of made it the interaction that I would have in my own office. So it's accepting each person's perception, relying on it as accurate, and then saying, what can we do that'll make this better? And even way back then, when the first book was published in 2005, I knew from my own experience and from treating women that progesterone was helpful. And so that's what I recommended. And so there's all kinds of information about how and why progesterone works. There's references, there's a glossary. So it's a woman-friendly book, but it's also good information. So we'll be giving away 2 copies, and happy to share that. And all of the royalties from the sale of that book go to help CeMCOR do more research.
That's amazing. I will make sure that we link the resources and the giveaway information below for our audience.
Good. Thank you very much, Eliza.
My pleasure, Dr. Prior. I have truly appreciated your time and your expertise. Your dedication to advancing women's health and providing accessible, evidence-based knowledge is truly inspiring. Thank you for helping us to understand and navigate the complexities of perimenopause. And to our audience listening, we hope that today's conversation has been both enlightening and empowering. Be sure to explore the Center for Menstrual Cycle and Ovulation Research for more information on managing hormonal health. Thank you all for joining us for the Holistic Menopause Solutions Summit, and we'll see you at the next session.